Week 34. Oh, man.
Good afternoon, everyone, and welcome to 34th week of the Native Strong Town Hall on the COVID-19 response and pandemic. Lately, it's been very vaccine-focused, holiday-focused. Thank you all for joining us. Those of you who are repeat customers or repeat visitors, we welcome you back. Thank you if you are, this is your first time. We welcome you. We won't bite, we promise. Please, ask questions as we go through the session today. There may be some, who knows, breaking news during, halfway through as the FDA is kind of in discussions or in chambers, I guess, discussing the, possible release of the Pfizer vaccine. So with that, if you're joining us on Zoom, you can enter a question via the chat box, chat bubble that's at the bottom of your interface, your bottom of your screen. If you are joining us via Facebook Live, just drop in as a normal comment and we will go from there. We'll moderate those questions and get to those at the end of the session. So, kind of just sit tight and absorb everything, absorb the information that's coming at you, and we will get to those questions at the end. As in, every week, 33 weeks prior to this, our good friend Mark Denning is here as our moderator and kind of our connection to the community. He's here again today, and I will pass off to him to give his piece and, introduce us to our featured speaker, Dr. Lyle Ignace, again, as he has been here every week since the beginning as well. So thanks again, Mark, for being here, and thank you all for being here.
Wayne Boju and the way Magana Duke, not away Benazi, Indigenous cause, the main do them. Anishinaabe and Dow, Neopit and Donjaba, from born in Neopit and now live in the Milwaukee area. And it's been a ride, I'll tell you, to be a part of this. And I'm glad you're all here, be you live or watching this on tape. We get a lot of that recording. So if you're live, if you move your cursor around a little bit, that little arrow thing, sometimes people use a hand. You can move it up, down, to the side, depending on where your toolbar is. And you'll see a bubble that comes up and underneath it says chat. You can click on that, and what's going to appear on your screen is a place that says to everyone. That's where you're going to put in your question, or maybe you have a statement or some information. But we like questions a great deal, because this is where we can be factual rather than what people think and what they feel. You can also do private questions to other people that are on here, but please use the to everyone so we can all see what's on our minds, what we're thinking. Don't forget the question you have may be representative of 10 or 12 people that are watching afterwards. So don't be shy with those questions. Also, a reminder, we are, as we watch this, lucky enough to have internet. We are lucky enough to have access to a computer, and we are lucky enough to have time. A lot of our relatives don't. A lot of them are challenged in any one of those places. We know who they are, and we try to help them as best we can. And one of those ways is to get to questions that they may have, but they're not here because of work or circumstances of inaccessibility to the internet or computer. So please feel free to ask for them. Even though you may know the answer or think you know, you need some reassurance, please ask. We're in the middle of some very serious stuff, as folks will say, and I do. It is serious, and we need to be taking care of each other now, especially, but it has been a very long, slow, as they say, and we're in it together. So once again, if you have a question, either from yourself or someone else, please ask us either in that chat category, or even when we're not online, you're welcome to call the Gerald L. Ignace Health Center. Their phone number is right on your screen here, and they might have somebody that can get you to the answer that you're looking for when we're not online. So without further going through all of these smaller but larger points, we're going to turn this over to Dr. Lyle Ignace, the Gerald L. Ignace Indian Health Center. and he's got a lot of updating to do. And I apologize about missing last week. I was called away to a funeral, taking care of best I can. And these are all the questions from community members that they have way up north. So we'll see how far we get, but your question is important. You're with us. So Dr. Ignace, over to you, and welcome everyone. We'll see you soon.
Thank you. Thank you, Mark and Jeremiah, for the introduction. Week 34, and believe me, there's a lot going on right now. Right now, if you see me look to my right, that's only because I am also watching the FDA Vaccine Advisory Committee is ongoing right now, and I've been able to pull out some information from that, and I'll share that with you today during this session. So. As everyone knows, Operation Warp Speed, we've all heard about it. We've heard about the different platforms by which vaccines are being created and what companies that are actually that are at the doorstep now of the FDA looking for emergency use authorization. They've applied for that. The first one is Pfizer. We've heard a lot about Pfizer. Moderna, we haven't heard so much, only because Pfizer's taken up all of the oxygen in the room. But it's Pfizer. Next week will be Moderna. AstraZeneca will probably shortly follow that. And then there's two other biotech companies that are going to be in the spotlight here shortly as well. So these 4 different platforms set up with the U.S. government, with Pfizer, Moderna. And so let's just go through what the latest is. And so I've talked about the vaccine, and on different occasions, I've talked about the framework by which, once these vaccines get approved, the kind of the rationale and the phasing, the tiering of how individuals are going to be able to receive this vaccine. So phase 1 has been clearly identified as the main priority group. We are talking about healthcare workers. We're talking about healthcare institutions, hospitals, facilities. We're talking about our first responders, whether it be ambulance, fire crews, and police officers, first responders. So that's as that phase 1A. There's about 20 million, estimated 20 million people that fit into this category, and I'll tell you why that number is important. In phase 1B, this is looking very specifically at the high-risk groups, that we know, and as I've gone through these presentations, I've talked about what those high-risk groups are, and that's mainly our elderly, mainly our elders in the 70s, 60s, 70s, 80-year-old age groups. We're talking, even if we go a little more granular, who are we talking about? We are talking about individuals that live in nursing homes. These are assisted living homes, these are group homes, long-term care facilities. This is the group we're talking about when we talk about elders at high risk. And it's estimated there's about 3 million that fit into this category. And why is this important? Well, they make up less than 1% of the US population, but they account for over 40% of all fatalities. And that is a pretty dramatic number when you consider all of the demographics that have been involved in this whole process. After phase 1, we're talking about phase 2. We're talking about the kind of the working well, the individuals that have multiple high-risk conditions. We've talked about what those conditions are on several occasions, but these are the individuals that are kind of in that, not that top tier of risk, but that right next to it. They're number 2 in line. And there's about 87, 88 million individuals So uh, I'll go through this and we'll talk about why this approach and the rationale for this approach and who's to get the vaccine first. Now, I have this a little bit out of sequence, but I think it's important because when we talk about the vaccine, surveys have gone out. We've heard individuals, like half of the country will say, yes, I want this. No, I don't. When we talk about groups, demographic groups, racial groups, um, you know, the minority groups have less um, acknowledgement of wanting to get the vaccine, and there are racial and ethnic groups that they just don't believe in the vaccine and they want more information. So this is what this portion of, will be, to kind of talk through, why, not just why I'm comfortable with getting the vaccine, but why I think um, everyone should reconsider. If you're against getting the vaccine, maybe this presentation would help you reconsider that. So I know this is weird. I took a picture. This was right off of the TV that I'm watching. And it is the demographic profile of all of the volunteers in the Pfizer profile. And some of the things that I hear is whether or not age groups, is my age group involved in this? Is my ethnicity involved in this group? Is it just non-Hispanic whites in this, or is they're African Americans, Hispanics, are there natives, are there Hawaiians, are there Asians involved in this? The answer is yes. And so I want to go through this because it's important to realize that decisions like this at the FDA, they're not taken lightly. They are intended to capture this trial is intended to capture the the broadest of groups in the country, and to assure that all demographics, whether male, female, age groups are involved, racial and ethnic groups are represented in this group. The comorbidities are involved in this as well. So this is really well set up, and people are blinded to the vaccine. So when we look at this profile, we see that it is a pretty good representation, over 40,000 total. It's been evenly split between people who got the vaccine and people who got the placebo, evenly matched up in terms of gender, in terms of age distribution. The demographics are pretty even. When you get down to that midsection into the race and ethnic groups, we see that American Indians are represented in this study. 253, 0.6% of the study population was Native American. So that's pretty consistent with the US population, and how these 253 both were split between the vaccine and the placebo group. And so representation was made with American Indians in mind with this vaccine. So that should not be a deterrent in at least assurance to this group that natives were part of this vaccine. So it is a good representation of our group. Now, what's interesting that's going on right now. So you've heard, the FDA has come out with documents, and yes, they have. They've come out with documents. And so what's interesting about this is it's kind of a little bit backwards. So Pfizer submitted their papers. They submitted all their documents to the FDA and also to this vaccine advisory committee. Now, these are the advisory committee is independent of the FDA as an agency. The FDA as an agency has come out with some preliminary analysis and inferences to the data that they got. And they released that out a couple days ago, which is kind of interesting because if they've already released all of the information, given all the highlights to what they've seen, it kind of makes you wonder why they didn't just go ahead and make the decision then. But they did it. So they're following the process. The process is FDA, they have it, they reviewed it, they put out some papers and released it to the public. The advisory committee is going on right now. They will decide today whether or not they recommend. Now, that's not the final, because now it goes back to the FDA, and the FDA will make their decision. So, and follow with the advisory committee's recommendation. So these are some highlights, and I just wanted to show these and just go through them very quickly. You know, as I said, that profile, the age groups, the demographics, the racial and ethnic representation in this. So they have definitely shown that this vaccine does show pretty significant and well-documented protection, 95%. Now, they have volunteers of all different races, all different ages. They have people of different weights, categories. And so, again, well represented. People who've gotten this vaccine have not shown any serious side effects. If anything, they've shown some, I shouldn't say, they haven't shown any serious adverse events. They've had some side effects, but just like any vaccine, there is always some degree of side effects. And I'll go through some of those as we go through this. So as you can read, so one of the important points that I got from these papers was that the efficacy of the vaccine, so there's a 2-dose process, dose day 1, second dose day 21. What they've actually shown is that there's actually a 52% protection after the efficacy after the first dose, which I find that kind of interesting, is even after a single dose, 52%, but it rises even more dramatically once you get the second dose to a level of 95% efficacy. So that in itself is pretty dramatic. Even after one dose, if say you get the first dose, you don't get the second one, you still have some level of protection. However, I do recommend getting the second one since it does bolster your protection to a much higher degree and one of the reasons why they recommend getting the second dose is because it does get you to that 95%. So here is a graph, and I find this kind of interesting because it really helps explain as to what this vaccine does versus placebo, what occurs. So you have the X and the Y axis. You have on the bottom, the row is the days after dose 1. On the Y-axis is the incident rates of getting COVID. So you see 2 groups, one placebo group and the other the vaccinated group. And you can almost see immediately within a week the divergence of protection to COVID. People who get the placebo, their incident rates just keeps going up over time versus people who've gotten the vaccine is really flat and almost very high degree of protection after even getting the first dose. So now hidden kind of in this information that's coming out is, you know, they do recommend that this be a 2-dose vaccine, but what they actually, there actually is evidence to suggest that even after the first dose is that people are actually showing or demonstrating protection, immunity within 7 days after the first shot. So it's a pretty good indication that the body ramps up and is really effective in creating an immune antibody response even after 7 days. And so that is really good news. That is really good news. And so once you get the second shot, you can see that this is almost flat. And so hardly anybody has gotten COVID. Only one person got COVID after getting the second shot. So this is really a nice table how to showcase that. Now, over the last several days, there's been lots of talk, lots of discussions, lots of presentations, summits, hearings, and just a lot of talking points that are coming out. And it all revolves around Operation Warp Speed. So we know that the FDA, have a very high rate of confidence that this will be approved. And so once it gets approved, people need to realize that this isn't just it's not a military operation. This is a full, all of our transport systems, all of our distributors in the country are really part of this Operation Warp Speed, which makes it so interesting in how this is being put together. We have FedEx is involved. McKesson is involved. McKesson is a good distributor of pharmaceuticals and medical supplies, durable medical equipment. They already exist. So McKesson is involved in this. UPS is involved in this. And they will all be distributing supplies in these thermo boxes that they've created. They've tested them. They've got GPS monitoring. They can track it from the time it leaves. It's an original spot to when it lands and when it gets from where it lands to where it goes to the institution. And so this is really sophisticated stuff, what's been created. So we have a company called Thermo Fisher Scientific, where they actually create the cold storage units that are needed to house all these vaccines. And so they were there. They talked about their machines, how their smaller versions can hold up to 5,000 vaccines. Some of their bigger standard units can hold up to 30,000 vaccines. Walmart, CVS, all have been enrolled and enlisted as vaccinators. So, Walmart, once this goes out into, this phase 2, CVS, Walmart, the pharmacies are going to be involved in vaccinations. And so this is really amazing how all different aspects of what we take, I think we take for granted a little bit, where it doesn't matter how it gets to us, it just gets to us. And UPS, FedEx, McKesson, these are companies that we utilize to help supply us on a regular basis, and they're going to be a big part of this distribution. So in terms of some of the aspects, once this gets approved, as I mentioned, healthcare workers and individuals who work in assisted living areas and other essential healthcare workers, that is going to be the initial group. Phase 2 would expand to other critical populations, and that is yet to be determined. That's where the next step after today, after the FDA finally does put its signature on this, it will go to the CDC. The CDC puts its final recommendations as to how and who, or the who, gets the vaccine from here on out. But I have read in a few articles, Wisconsin healthcare workers will begin to be receiving the vaccine in January. So why January? Well, and I've been talking about today and how my facility, I work in Wisconsin, in Milwaukee, how I'm able to get it first before all other Wisconsin health workers, and I'll explain why that is here in a few minutes. So Wisconsin health workers, probably starting after the New Year's, and then widespread more vaccine clinics will start in April and May. to address the more general public as a whole that'll be eligible to get the vaccine at that time. So lots of stuff coming out. Now, once the FDA, this advisory committee comes out and gives the recommendations to follow through with the approval, the FDA comes in, they will say, okay, our advisory committee recommends that we approve it. We're going to finally approve it. Okay. And then the CDC comes in, steps in and says, okay, FDA has now approved it. Now we will dispense into the framework of phase 1A/B, 2, 3, and start outlining that framework. Now, the initial group, the initial doses that will go out will go to 64 jurisdictions. Now, 64 jurisdictions speaks specifically to going to states, to territories, and other jurisdictions. So other Commonwealths like Puerto Rico and other Commonwealth states, that's all part of that 64. So now states will get it, territories, jurisdictions will get it, and 5 federal agencies. Now, these are the 5 federal agencies that I'm talking about and how my agency may be able to get this vaccine before the state of Wisconsin does. So the Bureau of Prisons is one, Department of Defense, the State Department, the VA, and the Indian Health Service. So GLIC, Gerald L. Ignace Indian Health Center, is an urban Indian health center. It is part of the Indian Health Service. So there's going to be an allotment of vaccine delivered as a government agency. It is going to be delivered as one of the 5 agencies from within the Indian Health Service. From there, it will get to the tribes. It will also get to the urban centers in short order. So now IHS gets an allotment, as a federal agency gets an allotment. The state gets an allotment. The state, once they get theirs, they will have to determine how the process will be to how to distribute to all of these health centers in the state of Wisconsin. IHS only has to worry about like 12 sites in the state of Wisconsin, versus the state itself has to worry about over several hundred either hospitals or health centers throughout the state. So it's going to take some time for this to trickle through the state. It will take less time for the Indian Health Service to distribute to their designated sites here in Wisconsin. So that's how we, as our health agency, will see this vaccine sooner than the state of Wisconsin will. So once this gets approved, General Perna, he is the one you see on TV. He oversees the logistics. This is the military portion, the military arm of distribution of the vaccine from Pfizer and BioNTech to distribute to all of the federal agencies and the jurisdictions in the country. So that is his job. Once it gets to the states, it is the state's job to then start distributing and dispersing the allotments. This is going to first start with almost 3 million doses. Once this gets cleared by the FDA and the CDC, they could start to distribute as early as tonight. That's how quick they're going to move. So this vaccine could occur as early as tonight or first thing in the morning. But once it gets approved by the FDA, it is go time to start shipping these out. Near 3 million doses immediately. They set aside the second dose, 3 million. So that will arrive when it comes time to get to the second dose. They've also reserved 500,000 doses set aside just to make sure in case of an emergency. I don't know what the scenario of that would be, but that would be a set aside to be in the back pocket in case of, or if there's additional areas that maybe the CDC may recommend that gets early vaccinations, so that they can accommodate that if any last second changes do occur. So 3 million could be sent in the air as early as tonight after this advisory committee is talking. So the advisory committee, that is what is going on right now. They are still talking as of right now. They're still asking questions. So this is going to be, this has been a very transparent, very public approach to their process. So this is an independent group. It's not related to FDA. They're meeting right now. They should, once they close this meeting out and come to a decision, it could be as early tonight. And so that means once FDA approves it, it can be ready for distribution. Now, I had mentioned one other group, another committee out of the CDC, Centers for Disease Control and Prevention. They will meet tomorrow and maybe Sunday. This is a group that's going to recommend officially who should receive that first dose. Now, I think for all intents and purposes, they've already established what that is. They've been talking about this for several months. Pretty much as soon as they thought they had a vaccine, viable vaccine for approval, they've already had this in mind. They've had this framework. All of the government agencies have been operating under this guidance and direction. IHS has been working through this. All of the states, Department of Defense, all of these federal agencies have been working under these frameworks. And so everything's been created to this point. If anything changes to this phase 1, phase 2, phase 3 approach, it would be a pretty dramatic change and would probably delay not only the allocation, but also the inoculation of the vaccine. So I can't foresee this changing a whole lot, which already has been put out. But once they do finally give their kind of official framework as to who gets the first dose, the first dose could be as early as this weekend. Like I've mentioned, they'll meet tomorrow. They'll make their final recommendations Friday. If there is vaccine on the ground in a health agency and they give their final approval with the recommendations and how and who, they can start doing it as early as tomorrow night or maybe Saturday, and more widely on Monday. So that's where we're at on the vaccine front. They are still talking. They're still asking questions right now. So it's kind of boring. It's not very interesting at all. So I wouldn't recommend watching it unless you feel like you have insomnia and need to get some sleep, and then feel free to watch it. But I'm giving you the highlights. So now something came up and kind of a surprise moment, and I'll just bring this up because Pfizer was approved in Bahrain and the UK. They approved the vaccine, and so they had already gotten their batch of vaccine, and they actually started their vaccine campaign a couple of days ago. Now, this was the profile coming out of the UK as to people between the ages of 16 and 55. What type of side effects are we talking about if you get this, if you get the vaccine? So they said between the ages of 16 and 55, half have developed some level of fatigue, half reported some headaches, 1/3 felt chills, 33% felt muscle ache, and half of those over the age of 55 felt fatigue. 1/3 developed headaches, chills, muscle aches. So this is, if for people who are watching this, I don't think you should necessarily feel like this is any big surprise. This is what's generally discussed for people who've gotten the flu vaccine. And what a good portion of us who've gotten the flu vaccine even this year have probably felt. I had the flu vaccine. I felt kind of achy. I kind of had a little bit of a headache. I didn't really develop the fever and chills, but I just felt like, I'm kind of off a little bit. I took an ibuprofen. By the next day, I was back to work, and everything was ship shape. So this shouldn't surprise you. I don't think it should scare you. The fact that this is being, all this information about the vaccine is being so openly discussed and published and talked about, these profiles, this doesn't surprise me. In fact, this is what I would probably tell every year, flu season, what my clients, when you get the vaccine, you will find that you will have maybe some aches, maybe chills or a fever. You may feel tired. You may get a headache. You may get some local irritation. Expect it. This is what it's all part of when you get the vaccine. Doesn't mean you're going to get the flu. This is your body trying to mount a response to the vaccine. So don't be surprised. Now, two people, one big event, I don't know if anybody heard about this, is that there were two serious reactions that occurred in the UK. Now, they published this yesterday and the day before, as you know, when they started vaccinating. The people with allergic reactions or a history of allergic reactions, whether that be to medicine, whether that be food, or even other to prior vaccines. Two people who have known adverse anaphylactic reactions to, probably medication or flu, they actually decided to go ahead and get the vaccine, but they did it. And when, if anybody knows anybody who has bad allergic reactions to, let's say, peanuts or eggs or bee stings, we talk about EpiPens. Carry an EpiPen that helps you overcome an adverse reaction. So two people who had EpiPens, got the vaccine knowing that this could occur, and rightly so, had to use their EpiPen and actually had to be hospitalized after getting the vaccine. Now, interestingly enough, the profile in the Pfizer volunteers, they did not. None of the people enrolled were of people who had adverse anaphylactic reactions to prior vaccines. They excluded them from this study. Now, as a result, they have now come out and said, well, people who have had adverse reactions, anaphylactic reactions to medications or even prior vaccines of any nature should not get this vaccine. Now, the only caveat to this is I would say, if you developed a clear anaphylactic reaction, you should not get this. If there's a questionable history of, maybe I have milk allergies, lactose intolerance, that doesn't qualify. Maybe I took an antibiotic a long time ago and I think that's not a clear anaphylactic reaction. A clear anaphylactic reaction would be I take something, I get so sick, I end up going into the hospital just because of such bad hives. I get short of breath, my heart rate, I start sweating, I passed out. That's the kind of reaction that I'm talking about. So keep that in mind. So let me get through some numbers really quick. I'm trying to condense this to just the salient points. But as of today, 68 million people across the world, almost 1.6 million fatalities. Here in the United States, over 15 million cases now. We've tested 210 million individual tests have been done. 285,351 fatalities. Here in Wisconsin, 422,000. The number who have recovered, 363, over 80%, and the fatalities are 3,887. Let's get into the Indian Health Service numbers. So I follow this and track this over time and give you guys updates as to how Indian country is doing on a weekly basis. There are 12 areas that represent the United States. Each area has its own level of activity and surging numbers. This week, as you see, December 8th, I have the profile in yellow or not. It's the ones that are highlighted in yellow that have shown and indicate there is a continuing surge or increase in numbers. So Alaska has been surging, California has been surging, Nashville, Navajo Nation is surging again. Oklahoma City is surging, Portland and Tucson. Now, the most striking thing here is if you just see a number, it doesn't mean a whole lot, but when you take it in context, we see that in the context here is 9,157 positive cases this week alone. That is the highest number of cases in Indian country to date. If we thought, several weeks ago when we got to 8,700, that was a lot. That was not the highest. We have now breached that and have gone over 9,100 cases. So this week, and you can see where the areas in the country are have the most activity. In particular, we're talking about Navajo, Oklahoma. These are the two highest surging portions in the country that have the highest number of cases. And so they are the ones that are trending and really representing the majority of the new cases that are going on. So it's those areas, those regions of the country that are the most worrisome right now. So the activity beyond the Indian health system, we have a health system outside in rural areas, in urban areas, and the health system that records data represents not just IHS numbers, but also includes the general public numbers. And what you can see here is that with every state, the number of cases in totality far out exceed the number of cases in IHS. So I estimate that there is 40% more cases outside of the Indian Health Service. So whatever the Indian Health Service reports out as terms of numbers, multiply that by 40% will give you a more accurate estimation of how many native cases that are occurring in the country. So 40% more than what the Indian Health Service has listed out. And so that's pretty significant because, usually we rely, Indian health centers rely on IHS numbers. Well, the numbers are higher when you include activity outside of the system. So looking at here in Wisconsin and the surrounding states, Michigan, 415,000, Indiana, almost 400,000, Illinois, 812,000 cases, Minnesota, 363, and obviously here in Wisconsin, 422. So, I had mentioned in previous sessions, Wisconsin was surging a lot faster than all these other states at one point. And we have started to decrease. The numbers have cooled off. And so now that Wisconsin numbers are coming down, these other states are starting to come up. And when we get into more specifics as to the states, particularly here in Michigan, we have the 12 tribes, the counties that represent these tribes. We see December 9th, the total aggregate to date. And then to the right-hand side, the far right, we see another December 9th. That is the difference between the 9th and the 2nd. So that's the number of new cases in that week. And there's only a few areas in Michigan, in particular, Lakeview and Grand Traverse, that have an upward trend of activity going on in their respective counties. So a little worrisome for those. Otherwise, the other counties that represent indirectly to the tribes, their trends have been decreasing. So what's going on in Michigan? There are now 2,000 cases in the state of Michigan. That's 196 new cases from the week prior. Of the estimated nearly 60,000 self-identified in the state of Michigan, this 2,000 represents 3.3% of the native population there. Let's look at Minnesota. Minnesota, with the 11 tribes in Minnesota and the respective counties they reside in. Again, December 9th, the aggregated to the far right is the number of new cases in the past week. We see up and down with respect to every part, every county. The trends have been decreasing. However, Minnesota now has 3,345 new cases. That's 563 cases, new cases in the past week. Of the 75,000 self-identified in the state, this now represents 4.4% of natives in the state of Minnesota have had COVID. In Wisconsin, with the 11 tribes here, their respective counties, we see that the trend, while still, we see the December 9th aggregated, the far right, December 9th is the difference in number of cases in the past 7 days. We see that the activity has actually been trending downwards. And trending downwards where I feel is pretty significant. We haven't seen this kind of decrease in a while in Wisconsin. However, we now have 5,431 cases. It's 329 cases in the past week. Of the 51,500 cases here, that now represents 10.6% of the state of Wisconsin's native population has been confirmed positive for COVID. So as I mentioned, Michigan 3.3, Minnesota 4.4, Wisconsin is 10.6. So hopefully this slows down even more, and hopefully that doesn't show any increase in the other two states. So one thing I wanted to show, and it's kind of a different way to explain the activity. So I'm showing two pictures on the left, on the right, December 2nd, December 6th. The highlighted gray areas show where the incidence, the high incidence of cases are occurring in the state of Wisconsin. Now, several weeks ago, it was mainly just the Fox Valley. The Fox Valley, that's where you see the blue, Wisconsin in blue and the dark blue. That's the Fox Valley and the northeast portion of the state. Since about 3 weeks ago, this trend has been, it's moving westward. The higher incidence of cases is moving more rural, and it's moving westward from the Fox Valley and northwestern part of the state. And why this is so important is on December 6th, you see the heavily gray areas. and you see where the tribes are. So 3 weeks ago, the Fox Valley, so that's Stockbridge, Menominee, Oneida, Saucogin, Forest County, Fox Valley several weeks ago. Well, they are decreasing, okay, and it's moving westward. And now we're talking about the other tribes of Wisconsin, the northern parts, the northwestern parts. We're talking about Lac du Flambeau. We're talking about El Cio, Le Coudray, talking about Bad River, Red Cliff, St. Croix. This is where the virus is moving. It is moving westward. It is moving into these tribal counties. And so, and it's evidenced by the activity, the incidence rates that we're seeing, that I'm seeing in the state. So a lot of stuff is going on. And if you're traveling to those areas, that would be the area that I would suggest to avoid now. When we look at the activities that are going on throughout the country, again, we see November 25th, highly dense areas like, say, upper Midwest, Northern Plains. As time has gone by, we see some of these states losing its high incidence rates, and it's decreasing. We see Wisconsin dropping, Minnesota going up, North and South Dakota still high. So you just get a sense that this is moving. It moves throughout the country, and the activity, when we look at Wisconsin, currently is decreasing. So that is worthy of at least mentioning here in this discussion. Now, at one point, about 3 weeks ago, we were number 3 in the country in terms of the incidence cases per 100,000 by state. We are now number 19th. That is about where we probably should be in all of this. But Minnesota has gone up. Michigan is starting to go back up as well. Now, when we look to the far right, we see that the December 9th is the number of cases that have been confirmed in the past 7 days. We see California, Texas, Ohio, Pennsylvania, Illinois, Florida. These are the most populated, some of the most highly populated, dense states in the country. And it shouldn't be any surprise that these states have the most cases. The only surprise should be that they represent probably close to 40% of all new cases that are going on. Of these, like 7, 8 states, they comprise nearly 40% of all cases in the United States. When you start talking about the other states like Michigan, Arizona, Minnesota, you still keep going down, like Minnesota. You see Wisconsin. You know, these numbers are not as significant as, say, that, you know, California, 165, almost 165,000, or Texas of almost 90,000. You know, that seems like a lot. And when we're talking, that is a lot. That's a good portion of what, of all the cases in the United States are coming from these 2 states. Wisconsin's 31,000, not as significant. In fact, 5 times more in California than in Wisconsin. So everything's relative. And I think everyone needs to keep in mind that our numbers here in Wisconsin are certainly not as significant as they are in California, Texas, or Illinois. So keep that in mind. So just some quick roundabout in the realm of confirmed COVID positivity rates nationwide. We're currently at 11.6. Here in the Bemidji area, so that's Minnesota, Wisconsin, Michigan, 10.9%, lower than the national average. When we look at the states individually, now Bemidji area, that is IHS. When I talk about Michigan, Wisconsin, Minnesota, here the state positivity, that's the state generally as a whole. They're above the national average, but Michigan is 13.5%. Wisconsin still has a very high positivity rate of 29.5, but decreasing. Minnesota, 10.9%, but decreasing. So this is all, at least for Wisconsin, Minnesota, this is good news. Our rates are coming down, even in light of our rates are higher than the national rates. So Uh, all right. I had mentioned that the number of native cases here in Wisconsin, 5,431. The point of interest here is that the number of fatalities that have occurred to date is 56. That is 6 new fatalities in the past week. So still a very serious ongoing, not just in the number of cases, but the fatalities. The fatalities are now becoming more prominent in what's going on in Wisconsin. Looking at age demographics, it's one thing to see, all of the groups, 0 to 9, 10 to 19, 20 to 29 years of age. We have numbers to go along with that. So as we look across from date to December 9th, we see that all of the age groups, the trending is starting to drop. Now, from December 2nd to December 9th, these 2 dates, if you look at what has occurred prior to that, it was increasing per every age group, then it dropped, and then it's plateaued. We just had Thanksgiving, so this week is actually a pretty good representation of what was to occur as another surge due to Thanksgiving. But the numbers we're seeing now are a result of that. I would say we've decreased and now we've plateaued. The question is, where do we go from here going into the weekend and coming out? My sense is the numbers will start to go down. Our numbers, at least the trending indicates that it will go down. Just like I mentioned, the surge of cases, almost hitting 6,600 cases per day. We are now down to 3,853. We hadn't seen these lowish numbers since kind of mid-October. So as you can see, we had reached our peak. We started coming down. We're decreasing. This week is the result of Thanksgiving, and we've plateaued. And right before this session here, the number of new cases as of today was about 4,000. So pretty consistent with the activity, what averages out on a regular activity for a Thursday, would indicate that the numbers that will be going into this weekend will be decreasing. So we could be seeing this trend very well next week, going down even more. This is Wisconsin activities. I want to get to this slide here, as this is the most important one, especially as it comes to why the vaccine are coming out and why the vaccines are targeting the older age groups. So you look at the bottom portion of this graph and the table in the right lower hand corner, you see the age distribution of cases that have occurred over the past week. You see the number of hospitalizations by age group, how many ICU admissions by age group, and the number of fatalities. When I talk about this vaccine and who should get it and why, it gets a pretty clear indication as these numbers start going up and accelerating up, who is the highest at risk. It is our elders. It is, as you can see, even though they don't represent a high number of positive cases, the impact and the effect of individuals as we get older becomes so much greater, and ultimately can result in a very high fatality rate. And so once we get 60, 70, 80-year-old age groups, these are the high risk, and the absolute highest of risk are people in their 80s. Now, if you think about this, most of our elders in their 80s tend to reside not so much in the home, in a private home, but reside in nursing homes. And that's what we're seeing is this age group, these long-term care facilities, assisted livings, group homes, nursing homes. these are the individuals that are getting an impact the most significant. And this is why this age group has been chosen for its one of its first priorities to give the vaccine. So you can see why that is going to be part of the initial distribution. Because even if we can cut this in half, you can see how dramatic of an impact that could be. We look at one vaccine, 95% effectiveness in prevention. You can see how quickly we can impact not just hospitalizations, but how quickly we can impact the fatalities that are occurring as a result of the COVID. So with that, I'm going to turn this over to you guys, Mark and Jeremiah, for any questions, comments, thoughts, concerns, worries.
So one of the questions
Divyanis is going to sign with the Bucks.
is he? Well, let's hope so. That's for sure. Did that come across on a national hearing?
Yeah.
Say that. All right. So I got a few questions last week from a pregnant mom and her family because I was gone. I was at ceremonies. So here's the pregnancy questions, and they're around the vaccine. Mom hasn't gotten COVID-19. Pretty smaller community, but when it comes to a vaccine, a couple questions embedded. One, has it been reading this? Has it been tested with pregnant women? Any results different from others? And then, what happens if she just stays the course, doesn't get a vaccination, which it appears she's not in any of the tier groups? She would be probably April, May kind of thing. And then her concern was vaccinations and lactation, feeding a baby breast milk, right?
Yeah.
Is that a concern for vaccine use? So two of those there. Her concern about vaccination, and second, if she waits, then certainly feeding the baby is a concern. So that's kind of turning that over to you, Dr.
Yeah.
Amy.
So that's interesting because as the very first question, because as I was watching this advisory committee today, that was one of the first questions that was asked was, will it be safe for individuals pregnant to get the vaccine? Now, interestingly enough, the very first thing they had mentioned was that there were no pregnant women enrolled in this phase trial. So there's actually no data out of Pfizer specifically to this question. Now, what was interesting was that given that there was no enrolled individuals pregnant, they came to at least one of the panelists had come out with showing no contraindication as to why a pregnant woman could not get it. So none were enrolled, no indication or contradictions to suggest that the pregnant woman couldn't. What they came to was that this would have to be a decision, an individual decision at the point of eligibility, whether or not to weigh your options to get the vaccine or not to get the vaccine. Now, with that being said, now this would be a young person, maybe 20, 30s, early 40s individual, and with no underlying health risk. They would be in that phase 3 portion of vaccination. They would not be in that first phase. They would be in a phase 3. And so I think between now and April, we will have a better idea on this, how to answer this question. Should pregnant women get the vaccine? I think we'll have that as the numbers come out we will see and get a better answer to that question.
So that's good news, kind of just a happy accident for her. She also has 2 children. And then her follow-up question to that was, are children a part of this phase 1, phase 2, phase 3, if they fall into at-risk health categories, or are children just going to be left out of this completely until maybe 2022? I don't know. Just throwing that out there. That's why the question.
So I want to ask everyone to close their eyes because I'm going to zoom really quick back to this, the picture demographics that I showed early on. I don't want to get people there. So in this trial of Pfizer, they only recruited individuals, enrolled individuals 16 and older, nobody less than 16. This was kind of like, you want to say, the first phase of their phase 3 trial, where they had 16 and older of all different age groups, 16 and older. That was that first portion of this test of Pfizer's vaccine. They are now, so they can only recommend based on age. Now, the kind of second portion or second grouping of this phase trial is to include individuals less than the age of 16. They need to enroll people, and that is an ongoing process, so they cannot make, they're not releasing any data information on people less than 16, or are they, or should they make any recommendation for people less than the age of 16. So now the upside, or I should, well, the positive side to being less than 15 is, yes, individuals less than 15 do get COVID, not at the rate that other age groups get, but the impact and the severity of COVID seems to be pretty mild to moderate. Rarely do individuals, kids 15 or less, get hospitalized. Even fewer get admitted to the hospital. And in the state of Wisconsin, there's been no fatalities between the ages of 0 and 29 to date. So, you know, whether or not kids should get vaccinated, you know, if we're talking 15 and younger, my thoughts would be probably not. And they may never come to a conclusion whether or not kids less than 16 should get vaccinated, because their course is pretty mild and haven't exhibited any fatal outcomes.
That's a great segue. Same family question around children. Just this kind of was around the baby. You know, as hopefully everything goes well out there. Is COVID-19 to such serious effect that there's an anticipation that in that battery of shots that children get, that a vaccine or a shot for children or babies is going to be happening within, you know, 3-4 years? I mean, I know that's really looking out there, but just as a healthcare issue, do you anticipate babies getting vaccinated, this kind of thing included into their battery of shots that they get before they're 2 years old?
Yeah, I wouldn't recommend it right now, just given the numbers that are being produced. You know, like I mentioned, you know, kids, toddlers, yeah, they may get it, but they really don't, aside from maybe a cold-like symptoms, they really fare pretty well. And if that's the case, that don't result in even being hospitalized, I don't see the reason or the need to vaccinate toddlers or kids if this is just going to be such a limited short course at all.
So I turned the page here and they had one more question, and that was about premature babies. Any information on premature babies in any of this? around COVID-19?
No data to report on, and I wouldn't want to speculate.
Okay. Then the next question came from the grandma. She's pretty hip. I couldn't answer it. When it comes to a vaccine, COVID-19 in specific, is this stopping the infection, or is it stopping the results of the infection? I mean, what she's getting at as a worker in a school lunch person worker is, hey, someone gets a vaccine, they're great, but yet so they're not affected, but they're shedding virus like crazy, right? So they're showing up to work, and everybody else is like, hey, what's going on, and no one knows what's happening. So it's not a little question.
Yep.
It was a good one though. So any information on that one?
Yeah. So when we talk about the vaccine, so individuals who get the vaccine, what does it actually do? Well, the vaccine itself won't protect you against the virus. It is your body's ability to mount an immune response, an antibody response in your system. That, as a result, will help prevent you from getting infected. Okay. Now, that doesn't mean you can't be exposed to it. You could. You could still be exposed. Now, it can not only prevent the infection from occurring, but even if you do get infected as a result of the coronavirus, your symptoms, it does, as from what I've heard in this advisory committee, that it actually could actually prevent severity of disease and even hospitalizations. So, and that should be a clear message, as to say, not only can it prevent you from getting infected, but even if you do get it, your symptoms may be of a mild cold at best. It could actually prevent you from being admitted to the hospital and actually prevent a fatal outcome. That's how good this vaccine is right now. And that's what this advisory committee has come out with, and saying that it could actually prevent severity of disease.
So that goes to the question, right? I mean, and I don't know if there's an answer to it. Is someone's got COVID-19, they took the vaccine. Let's say we're looking at springtime flu season, and hey, man, I don't even need to get tested. I feel fine. I got it over the weekend. I'm going in on Monday, but they could be throwing off COVID-19, even though it's kind of being treated like a flu. Is that right?
So,
you see what I'm saying?
Yeah. So it's just like getting a cold or getting the flu. Even after you get the vaccine for the flu, you can still get the flu. It's just that it won't be bad. It won't be a bad flu. It could just be a runny nose and a sore throat and maybe a cough, and that'll be it. Now, I think the question is, even if you get the vaccine and it causes an antibody response to protect you, could you still be transmitting the virus? And there is a probability that yes, that could still occur, even if you don't get infected. You could be I wouldn't say a carrier, but a possible transmitter of the virus, even though you have no symptoms and you're protected by getting the vaccine.
So I'm hoping some anti-vaxxers out there are hearing this particular point, because if and there's lots of assumptions here. That assumption being, hey, I had just a little bit of a cough, I had the vaccine, I'm doing fine. They show up to work and then they're shitting virus. All the anti-vaxxers get to be at risk, and those folks that kind of are around them get to be at risk. So I would assume your recommendation would be that if someone chooses to get the vaccine, they choose to get it kind of sooner than later, because spring is that cold and flu season, and you don't know what that cold is going to be. So I don't know if there's going to be testing as much come spring, or if it's going to be even more needed, because now people are getting just a smaller kind of cold or flu, not knowing what it is and not knowing when to report to work. You see what I'm saying?
Yeah.
I mean, it seems like there might be an industry or some precautions around that need to be thought about. Because once a person gets a flu, what kind is it? and I need to figure that out before I go to work. I don't know if that makes any sense.
No, it does. And this, it kind of, if you were to take it one step further in this whole idea, this concept of herd immunity, this point of herd immunity really will depend on when this virus becomes, I wouldn't say obsolete, or becomes inactive in the community, in any community. You need to have a level of protection or people who've gotten COVID in a community to render this virus ineffective in causing outbreaks. Okay. So it's not that if we get to herd immunity point and people are either vaccinated or have gotten it, that the virus won't exist in circulation. It still can. It's just that you have such a high degree of people either vaccinated or who've gotten it. There's nowhere for this virus to infect more and more people because everyone's either protected or has already gotten it. So it makes it almost to the effect of the common, I wouldn't say that's just the common cold, because people can still get it. It's just that it won't be an active, contagious spreader of completely nobody's seen it. Now we've all seen it, and now it's the people who don't get it or who haven't gotten it or haven't gotten the vaccine that will get it. These will be as you mentioned, the anti-vaxxers who haven't gotten COVID or the vaccine who are going to be the most susceptible to it.
So that was going to be my follow-up part. I was going to take a hard right turn into Ayn Rand territory on the individualism perspective, meaning those folks who identify as Republicans mostly identify as individuals, individualistic behavior, freedom, rights, all that kind of stuff. Important stuff, of course, but meaning when you say that COVID-19 becomes ineffective, that means for society or a we or as a group, doesn't mean that individuals won't be affected by it, or potentially that individual being just as severely as affected by it as they would have months before, correct? That it may still be around, and if it hits someone who's not protected, it could have some pretty dire outcomes for that individual. Yeah. So not the neighborhood they're in, not the community that's around them, but for that individual person, it could have some dire consequences when they run into it, because even with herd immunity, they're still at risk. Is that what I'm hearing?
Yep. And think of it like the Iron Dome. The Iron Dome. Once you have a community that has either gotten it or protected with the vaccine, that group can't get it, and it acts as a shield, so to speak, and can't get into the community because it won't be transmitted. It won't be an infectious contagion within a community, and it can't bounce infection to infection to infection to person to exponential growth, not like it is when it first started. It could still cause infections. It may cause many outbreaks, like maybe a family home may get COVID, but it stops there because everyone that they're in contact with has either gotten it or they've been vaccinated. So it's really the ones that have not gotten it or not vaccinated. Those are going to be the most susceptible as time goes by, even further out, even into next summer. If you're lucky to have not gotten it or vaccinated, and those are the group that will always be susceptible. So, and it can still have its same effect, causing a bad, flu, could land you in the hospital, could have, fatal outcome. That's still a real situation. It's not making the virus less lethal. It is lethal in and of itself, and that will never change.
So back to the questions I was getting at ceremonies. There's a few others here. One was about Native communities in specific, meaning the reports have been out about a disproportionate cases in marginalized communities, brown communities, minority communities, in other words. For Native Americans, is anybody or has anybody looked at is there disproportionate spread in our community? And if so, why? I mean, we've speculated it between you and I. It just kind of makes sense as a community. It can be a issue like our strength becomes a weakness. But has anybody looked at that and said, hey, you know, that's not true? Or now that we're seeing another spike in Navajo country, certainly someone has to be looking at the whys and wherefores on what's happening there.
Yeah, and it's quite possible they are. It just there's no good researchable data out there, published articles to suggest one way or the other. I mean, we certainly have our own personal theories and assumptions, but there's nothing been proven out there. Now, the only thing that kind of gets around that is, and this would take some heavy duty researching and some pretty good statisticians. But we know that the incidence rates compared to all other races here in Wisconsin, natives have the highest rate. We have 102. We have the second highest rate in the state of Wisconsin. Hispanics have the highest rate. Then it's natives, then blacks, then whites, and then Asians. That's the order sequence of cases. Now, when it comes to hospitalizations, when it comes to fatalities, the ultimate end here, natives have the highest rate in the state of Wisconsin at 102 per 100,000. Then it's African Americans at 84, whites at 66, Hispanics at 62, Asians at 40. And so that's the only way you could look at this, is looking at the incidence rates, but then you can look at specifically tribal, and that's kind of the back way that I've tried to answer this question, is where is all the cases occurring in the tribes in the state. And you can only really follow that unless the tribe comes out and says, hey, X tribe had 1,111 cases, versus another tribe that had one case. It really does come down to reporting and data and accurate information. And you can make inferences, but it would take a pretty hard, long study. We may never be able to figure this out for a couple of years.
I'm gonna and this one comes from me. These were coming from other folks. I'm gonna save the other few for next week. So here's what a couple things. One is the Pew Research rate came out a couple days ago and was talking about how majority of Americans, maybe 6 out of 10, they're feeling favorable to the vaccine. Doesn't mean they're going to get it. A lot of people saying, well, I'm going to sit it out and wait and see what happens. But how many of those Americans that they're asking out of that 10 would you feel comfortable as a doctor saying, yeah, that's the number out of 10 people in a room I want to see vaccinated? Is it 6 out of 10? Is it 7 out of 10? Is it 10 out of 10? Now we're talking about adults here at 18 to right on through upper ages. So what's kind of your look at that number? I mean, it must be encouraging, but is that the number we're looking for? 6 out of 10 say they're feeling favorable, and looks like we'll get to the number we need to get vaccinated, or are you still pretty concerned about that?
I am, as for natives, if we're talking natives, if I hear 6 out of 10 will take the vaccine, I would be pretty happy with that right now. I would be happy with that. If it was higher, that's gravy. It's just gravy all day. If you start hearing like 4 out of 10, 3 out of 10 would take it, that we're going to be in for a very, very, very long haul here if we start seeing that penetration of vaccine in the communities. It's just, it will prolong, and it will be we'll be talking many, many more weeks about the same issue about this virus.
So what I want to back up and say that Pew Research was about Americans overall. It wasn't Native American community, but that leads to the last question for me today. And that one's pretty specific to Native community. I think it's important that we figure out where this is spreading in Native community and how it's spreading, because we, as other marginalized communities, have a distrust of the government. The whole thing I grew up with, with my own mom, say, you get a knock on the door, I'm from the government and I'm here to help you. It just replete in Menominee history about that not being the case. And then now we're going to have government workers out there saying, knock on the door and say, I'm here to help you. Yet again, here we go again. Is there any sort of Indian Health Service strategy on how to up the trust in vaccine, people accepting the vaccine in our communities? That's, and I do mean culturally specific, culturally sensitive messaging, or is that something that's going to have to be delivered clinic by clinic as far as what they understand their community to be? Is there something out there that's culturally sensitive, appropriate, and targeted for a population to up that level of trust?
This is kind of the discussion that as a Native provider, I almost have to go through every year, particularly when it comes to the flu season. And you always think, well, next year I'm going to get more people vaccinated for the flu. Well, it's always the same ones that you can convince. You can't convince a group of people that never want it, never get it, or feel they're never going to get COVID or ever get the flu. They're never going to want the flu vaccine. And it's going to be pretty hard to convince individuals like that. Now, people can have their prior experiences and their own personal views and thoughts, as you mentioned, Mark. And I think when it comes to convincing individuals, it's kind of like you got to walk the walk and talk the talk. But you also have to back this up with information. So it's not good enough for me to say, hey, take the shot, it's great, no problems, you'll be skating all day. It's pictures like this. It's pictures of showing representation that in this vaccine, this trial, and this enrollment, Natives were not excluded. We're part of this. And I will tell you this, of the 131 people that got this vaccine, none of them got COVID. The only Native that did get it was in the placebo group. Any Native who got this vaccine got COVID. So, and as far as I know, there are reports of some side effects, but there weren't any adverse events. So it's tolerated very well. And if it's tolerated well and shown to be effective, there's just so much I could say until I'm blue in the face that will either convince someone to say yes or convince them or reaffirm their no. All I can do is show the data. This is why I picked this out. Of all the slides I was seeing, this was the only one I thought would be of any use to show how we're represented in this vaccine trial that may convince you that, hey, Natives are part of this, they got it, and they got protected, and they did fine.
It's and not a question behind this, but this is why I like this conversation, native conversations, is because we can do things like here's the data, 131 natives, okay, coming out pretty good, no huge long-term side effects being shown, but we also on the other side are seeing the second highest ratio of spread in number one in fatalities. So those are facts, and I would think that the average person on the street or parent at a school doesn't know those things. That's why we're having this conversation. And hopefully when people are speeding through this stuff, this is where I, as a lecturer at the university, wave my hands, move around a lot, because then people kind of stop because they want to know what's going on. And what we just talked about with some data that will help people understand why vaccination is important to our Native population. Well, all populations, but specifically in this conversation, it needs to be had between Native people. So I'm going to turn this, yeah, go ahead.
I will say this, just to follow up, I mean, between you and me,
Yeah.
we could figure out, we probably know people who know of the families of the members who passed away because of COVID. We could probably figure it out. At least a good majority of them. I know I've had family members, and so we could figure it out, and I could piece this together because of the individuals I know personally. There were a lot of health related, and those would have been the individuals I would have taken them myself to the clinic and say, we're not leaving until you get a vaccine. The young, healthy individual, I'm never going to be able to convince them, and they probably don't need it, okay? But I'm talking about our elders. I'm talking about our aunts and uncles who have multiple risk factors, who are definitely in that category of high risk, not only for getting severe disease, but being in the hospital, and even higher risk for fatalities. These are the group. These are the individuals. These are the individuals that we have to protect. These are the ones that are the most vulnerable and at high risk of not coming home.
So Dr. Ignace, you get the last word on this program. Apologies about last week. I was in a place that didn't get a signal, and sad event, but we're back in the saddle, and let's keep doing this till we get some moving all those numbers that seem to be going in the right direction right now. Yep. Keep them going in that right direction. Thanks for what you do. You have the last word for this week's program, and we'll see you next week.
So thanks, Mark. And that light at the tunnel, it's getting brighter. It's getting brighter. Right now, as I mentioned, the FDA advisory committee is meeting. They're actually voting right now. So a decision is coming. And once that decision is made, we could be seeing huge impacts with this vaccine in short order. And this Christmas may be completely different than what we were talking about on Thanksgiving. That's how dramatic of a change this could be occurring. My parting thought here is that it's been a long year in all kinds of ways, and COVID-19 has wreaked havoc in everyone's lives. For us to be on the precipice of a vaccine, I can't stress this enough, how important when that time comes, if it's highly indicated and would help prevent you from getting infected with this virus and could prevent a bad outcome, I would highly recommend that you consider taking and getting the vaccine. That's how close we are getting to a decision that every single one of us will need to make. So between now, today, and when that decision for you comes, stay safe and stay healthy and be strong. So until next week, take care.